Hey, good morning, everybody. My name is Peter O'Connor, and welcome to this session sponsored by Cook, the AAO's Thought Leadership Series. I'm joined today by two of my colleagues, Tucker Woodson from up in Wisconsin, and Paul Schalch down in San Diego. So coming to you from various corners of the United States today. I'm up here in Maine. And just in reference, there's another pre-recorded session which kind of has a little bit more detail in terms of considerations that you might want to think about for snoring management in the office setting. So I'll review a little bit of that here in a series of slides, and then we'll get right into the Q&A. But again, that on-demand session's available, where I had an opportunity to share some thoughts on just in general problems with snoring, how to evaluate the snoring patient when they show up, and then a more in-depth review of snoring procedures. It's hard to do in an hour, but touched on a number of common topics, and then some non-surgical treatments as well. And we'll touch on some of those things today, and maybe hopefully have an opportunity to clarify some things in the Q&A for anybody attending. So again, thank you for Cook and the AAO for sponsoring the sessions and the time here where we can't all join together. Hopefully next year we'll be able to do that. But just in general disclosures, these are private views of the speakers, and you know, we're sponsored here by Cook Medical, so we appreciate that very much, along with the other industry leaders doing similar things. Okay, so just very briefly again, the problem with snoring. Depending on the data you look at, it could be up to a third of the US population that snores on a regular basis at least 3 times a week. It's probably more than that in a less frequent period, but over probably 90+ million per the National Sleep Foundation. And some prevalence data shows even higher than that. The population, we think oftentimes maybe in that 40-50s range that shows up in our office to manage this or look for solutions. But in some studies, it's even younger than that, and a quarter of the population in the UK under 25 had some socially bothersome snoring. And that's oftentimes why patients show up or are referred in could be their dentist, their primary care, or then ENT. Or it might be a separate complaint when they're in the office. But most times it's a socially bothersome snoring that's bothering the bed partner. And one of the things I will do a lot of times is ask a patient why they had a sleep study done. And oftentimes it's because of this very fact. They were snoring, it was bothering their bed partner, and then they started to investigate what was going on with it. So snoring in and of itself, we know, is a presenting sign or symptom of OSA syndrome, and that should be investigated because we think that there's certainly, high morbidity in many patients that have obstructive sleep apnea, of course, but there's some data which also shows the morbidity with snoring. So even in the absence of obstructive sleep apnea syndrome. So there's a couple of articles and many more out there in terms of animal studies as well as human studies that relate heavy snoring independent of sleep apnea, increasing mortality. And it's perhaps thought to be through things like carotid atherosclerosis. So there's some data which shows that snoring in and of itself could be harmful and not just a socially bothersome problem. So it warrants kind of addressing it as much as we can and looking further in terms of what's going on with the patients. As far as managing it, when a patient shows up, and for those patients who complain or in your office complaining of snoring, overall, it's very difficult just based on physical exam to identify who has obstructive sleep apnea based on clinical exam alone. So weighted average from these studies, which were more extensive in terms of clinical examination features, including cephalograms, various measurements, various clinical characteristics. It was very hard to determine who and who did not have obstructive sleep apnea with high specificity sensitivity. So the weighted average is a little bit better than the flip of a coin. So bottom line, recommendation to have some sort of objective study to determine whether or not sleep apnea is present. It should be the first kind of jump off point for your evaluation and consideration of then addressing their snoring, because that's important from a morbidity standpoint. Aside from that, of course, the technology is much better now, and the smartphone apps and other wearable technology gives us some indication of regular snoring, and this is commonly, much more commonly used now. This paper here back in a few years back from Mac Camacho, one of our colleagues, and Robson Capasso out at Stanford has continued a lot of this work to look at kind of what smartphone apps are doing and other wearable technologies. But it's a good kind of starting point for patients to come in and say, hey, this is what I'm experiencing. It's important to know what that evaluation is doing and if it's been validated in terms of other data in terms of sleep issues. But it does highlight that there's a variation in the quality of snoring, the presentation of the snoring. So those smartphone apps can be valuable sometimes. And there's a few that are listed here, but there's many more. The other important aspect of this is the quality of the snoring can be very different depending on where the sound is generated in the pharynx, we think, as well as the stage of sleep. And the top left of this shows kind of a difference in the character of the wave, depending on the stage of sleep a person's in. And then there's some other research. This paper here referenced on the bottom is by Scott Britsky and Eric Mayer, where they looked and they used sound analysis to determine as a predictive value whether or not a palatal procedure specifically for snoring could determine that the sound characteristic could help them determine success. So that's important, and just kind of understanding the character and the frequency of the snoring. This is a little more recent data out of some of our colleagues in Germany, which looks specifically at the different pharyngeal sounds based on obstructive patterns they noticed in sleep endoscopy. Now, this is slightly different, but it highlights that the snoring sound and the limitation of airflow in the airway can be very different depending on what level we're talking about. So perhaps this will lead down the road to better patient selection and who we might consider for certain management therapies for snoring when they present, and how that analysis could be utilized. So as far as management in the office, there's procedures that can be done. We're going to focus primarily on palatal. We can comment a little bit on nasal things, but the focus of this will be on palatal procedures. There are certainly non-invasive things that have to be considered and might be warranted as first-line therapy for many of these patients, including oral appliances, some other positional techniques, including some of the newer vibratory devices that change the position of a patient and kind of not alert them awake from sleep, but help them maneuver to a different spot in a decubitus position or something where they might not snore as much. And then there are other things that you might come across or patients will ask you about, including weight loss and myofunctional exercises, as well as a variety of sprays, strips, bands, and then earplugs. Earplugs work. There's data that shows that if a bed partner wears earplugs, it improves sleep for both people. So that's a consideration as well. Sometimes that'll be worthy of discussion with patients in the office. As far as palatal procedures, this is kind of a little bit of a salad bar of different options here. The cautery-assisted palatal stiffening operation is one that some people can do in clinic. Has a little bit morbidity in terms of pain, perhaps. The anterior palatoplasty is an offshoot of that. First a modified capsule and then retermed by Kenny Pang as an anterior palatoplasty. And there are variations on this, including now using a barbed anterior palatoplasty, sometimes without resection of the tissue and just tightening the tissue with a barbed suture. And Boyd Gillespie has published some stuff on that as well. Injection snoroplasty, one of my colleagues, Scott Britsky and Eric Mayer, in the military, they had done this quite extensively, and other people have published on it as well. It's fairly simple in the clinic and low cost, and that might be an option for some of your patients. There are a variety of different radiofrequency ablation techniques which can be effective and can be repeated. And that's a consideration as well for certain patients. And then the implant kind of categories include the pillar implants, which have been well documented in terms of their utilization for snoring. A little harder to get now, and just changing hands with company availability and stuff like that. And then a newer alevoplasty, and we'll show an animation of that, which is an offshoot to some degree of an implant, but a resorbable implant versus the pillar. But it has a barbed characteristic which allows repositioning of the tissue, similar to some of what we might do in these other techniques, but easily deliverable in the clinic. So here's a couple of quick videos just as an idea of some of the things that can be done. The bottom left here is a technique, anterior palatoplasty, that I've applied in the clinic under local anesthesia. Here up into the palate, hard palate, soft palate junction. I have the patient hold a sweetheart retractor and sit upright. Counseling is important to kind of give them an idea of expectations and patient selection as well. And if you take off a little mucosa, submucosa, you can then plicate and kind of imbricate the tissues here to tighten things up. I do this more aggressively, of course, in the operating room, but for snoring, kind of removing this tissue, getting some scar generation there, I have found helpful to reduce the character of the snoring or change the character of the snoring and reduce the magnitude. And patients with good selection seem to tolerate this pretty well in the clinic. And then the other thing I find with this is I can reposition the tissues to a degree and get down into resecting or removing a little bit of webbing and repositioning that tissue as well. So that's one technique that I'll employ in the clinic. And I'll let that continue to play, and I'll bring up the injection snoroplasty here, which is another technique, which is just injection either with alcohol or another off-label use for sodium tetradecyl sulfate, which isn't always available, but it's a sclerosing agent. But that simple injection into the palate here with the injection develops some sclerosis over about a 4 to 6 week period. You get a little bit of swelling afterwards. Depending on how deep you are, it might be more extensive, but that will start to sclerose the tissue, and then you get some stiffening. So that's an important aspect of what's done there, but pretty quick in the clinic. It does require a little bit of chair time, but it's pretty easy to deploy in the clinic for most patients. I'm going to jump out to an animation here, just because I don't have a video of this on a patient, but this is a newer procedure with the alevoplasty, and I'll let this play through here for
the alevoplasty procedure is a minimally invasive in-office treatment for snoring. Mark the location of the 3 pilot holes. The optimal location is 5 to 6 millimeters distal to the hard, soft palate junction.
I would use for an anterior
Use a topical lidocaine spray.
Or any
then
of these
inject the patient's soft pellet with 1 to 3 small doses of lidocaine.
The difference is just for time brevity.
Insert approximately 1/3 of the intended implant depth.
Introduction
Repeat this
tool
step
to
2 more
develop
times.
these holes, and then
on each Alevo snoring intervention device,
through those holes.
Visually confirm that each suture implant is preloaded correctly.
Tool. And you can see that those are barbed, and this is a resorbable implant. And through this next little portion
Insert the device in a continuous arc motion
how this
until the depth insertion marker is fully submerged. Release the black disposable tension suture from the cleat. Retract the delivery tool using the same simple arc motion used during insertion.
So the barbs here really
Repeat
then
this step 2 more times.
Because you
Gently
still have
pull
that
on
suture,
each disposable
and then you can
tension
reposition
suture
the tissue.
so the implant does not extrude. 1 to 4 millimeters of lift is the goal.
And then these sutures are removed.
Cut the disposable tension sutures with scissors.
That's essentially it. So let me come out of that. I'll talk a little bit more about
the suture implant.
That alevoplasty is really a combination of repositioning tissue, but any of these techniques really are generating a wound of sorts in the let me go to the next slide. Generating a wound that then scars, and that palatal scar is what stiffens the palate, changes the characteristic of the snoring. But what's important in this is just to understand that palatal scar can remodel over time. And this is an example from some of the RFA literature from Boris Stuck in Germany. But this is common in terms of a lot of these techniques as they report their data at baseline, 90 days roughly after surgery, and then 100 days. There's a couple of studies with RFA out to 6 years, but a very similar pattern where probably that palatal scar remodels and you might get a little rebound. So for all of the palatal techniques that we're doing for snoring, that's an important thing to remember. Just some key points as I wrap this portion up. Who is the snoring problematic for? That's an important one. Most of the patients are coming in, I think, because it's a socially bothersome problem, and they want it resolved to help their bed partner. So that's important, and addressing that need is something to keep in mind. The other aspect I think is valuable is counseling and setting expectations for the patients. I've had a couple of patients come in and they bring their bed partner in, and they say they're continuing to snore. And when the patient themselves tries to demonstrate that, to me, in a couple of occasions, it sounded like they were just breathing or breathing hard, and that's what bothered the patient's bed partner. So it's very important for me to understand their expectations and then help kind of discuss those things as we went through options. And then none of the procedures really completely eliminate snoring. Whether it be a treatment or a procedure or an oral appliance, there can still be times, depending on a number of different factors, when a patient will snore. And I think that's important. I've learned having that discussion with patients is helpful for me as well. And some of the factors include kind of alcohol. If the patient has changed weight, that may change their snoring presentation over time. If they're sleep deprived, they tend to get into some of those deeper stages of sleep as they recover from that. And they may snore more there. And then certainly nasal congestion can play a role in that. So, and here's an example of, I think I was on my second liter here, but Dr. Woodson was still on his first, so I tended to snore a lot more that night. And I'm not sure about Stacy, but that was a picture from three of us, Stacy Ishman, Tucker, and myself in Germany at the sleep surgery meeting a couple of years ago. So with that, I will look here at the chat and I'll let Tucker and Paul jump in if they want to make any comments at this point. And then if you want to include your chat, we'll take a look at some of those questions. I'll start off by asking Paul and Tucker kind of what your preferred snoring procedure is. Is it something like a simple uvulectomy, palatal radiofrequency ablation, sclerotherapy, or some of the other techniques?
I'll jump in first. Do you hear my audio first?
Yeah, I'm hearing
okay,
you.
Good. All right, good. Thanks. Well, it's great to be here. Nice overview. So from a procedure point of view, probably my most common is to use something more like a anterior palatoplasty. You know, one of the issues that I have in my practice and practice situation is reimbursement and cost. And so that, you know, there's always this balance between, in a sense, that the less invasive procedures are not generally covered by insurance. Mm-hmm. And the more, and so, you know, it gets to be really an issue of cost, especially when you looked like in the last slide with some of the relapse. So it really depends somewhat on your patient population and what they're looking for. So the pillar implants, the allevoplasties, the radiofrequency type procedures, at least in my practice, are a little more challenging, you know, due to cost. Some of the issues. So anterior palatoplasty is probably the most common procedure I do, although probably the majority of my patients are treated medically versus surgically, actually.
Okay. How about you, Paul?
Great. Well, in my case, I have quite a bit of experience using the pillar implants for a while. And very commonly, I would combine that with a uvulectomy, or at least a partial uvulectomy or shortening of the uvula. As you know, a lot of these snorers, you know, have very, very long uvulas. It's almost like a telltale, you know, that you can see in, you know, physical exam. You can really know who really has, you know, true snoring. And now increasingly, I've been actually using the allevoplasty. I jumped on it fairly early on, and I've done a few cases with it combined also with a uvula shortening, and that seems to be, you know, at least so far, successful in my hands. I think to your point, Peter, what you were mentioning about sort of establishing the expectations and the baseline for these patients initially, I've been actually encouraging them to use some of the smartphone-based apps to sort of bring in some recordings, you know, and so we can listen to the snoring together, you know, reach sort of like an agreement of, you know, what is actually the problem here, what are we seeking to accomplish, you know, how does the snoring sound to you versus how it sounds to me, and then of course to use that as a sort of tracking method or you know, a way of look at the outcomes afterwards to say, okay, listen, you know, compared to what it was before, see what it is now, it's improved. But it is very true that it's just very, very hard to make the snoring go away completely. So we're really just kind of moving the dial, you know, towards less snoring, and it's important to set those expectations realistically. And then to Dr. Woodson's point, of course, you know, in terms of reimbursement, that is always a challenge. You know, oftentimes these procedures are cash-based, and, you know, that's also an important discussion to have with the patient. And then lastly, I will very commonly combine these procedures with some sort of nasal intervention to try to improve nasal breathing. And that's, of course, something that can be done in the office as well, oftentimes at the same time. You know, with the caveat, of course, that sometimes if you improve nasal breathing, you can see some of that paradoxical snoring where the snoring can actually worsen. And that's something that I always bring up in my discussion as well.
Yeah, I think yeah, those are good points. I want to come back to the nasal stuff, get your some further input on that. But there's a chat comment here, just in regards to does anybody know when the pillar implants will become available again? I think it's kind of driven somewhat by, and I think there's a clinic in the Dallas area that really did a lot of this. I was previously lived in San Antonio, and I know that was commonplace for clinic up in Dallas to do that, a snoring and sleep apnea place up there. But I don't actually know kind of any updates on availability when it'd be out there. Do you know, Paul?
Yeah, I do. So the company, as you said, switched hands a couple of times, and then the late Craig Schwimmer acquired it and developed the Snoring Center in Dallas, like you said. And then, of course, with Craig's unfortunate passing a couple of years ago, I don't believe they're being produced anymore. And I don't think they're going to be available, at least not in the near future, if ever. So that's at least the latest I've heard.
Okay. All right. I mean, I think, you know, when I spent some time with Tucker in the past, there was quite a bit more of that being done in various offices and stuff. And for the right patient, I think those are effective. So if they are available, you know, that might be good. But there are certainly some other techniques. And as far as delivering and doing the alevoplasty versus the pillar, have you had any idea if there's some are more acceptable, less acceptable, one of those two techniques versus the other, Paul, in terms of pillar alevoplasty, how patients respond to it, in terms of the office procedure itself, how do they tolerate it?
In terms of how it's tolerated, I would say it's very similar. You know, with pillars, up until, you know, the time we were still doing them, you know, we were deploying upwards of 5 implants, and the process was the same. You know, just you know, topical anesthesia followed by infiltrating, you know, the actual sort of tissues of the palate and then deploying them. So in terms of discomfort or the way it's tolerated, I would say it's very similar. The advantage, of course, of the levo is the fact you can reposition the palate, and that doesn't seem to be, you know, too uncomfortable, and it seems to be well tolerated. Most of the discomfort I see is from actually when you do the partial uvulectomy, if anything.
Yeah, I would agree. So yeah, in the chat box here, there's also a comment from somebody that, you know, that the pillar did have FDA approval for OSA, which the alevoplasty does not. So we'll see, you know, data as it comes out down the road and as people use it, that may come. But right now, that is a good point that somebody brought that up. Just in general, Tucker, another question was, have you had an experience, or Paul, or either of you, where patients are able to get reimbursed for any of these procedures? Whether they be done in the office or you're combining them with something else, how do you tackle something like that? Or are these all out-of-pocket costs for patients? That's my understanding for snoring. I've never seen that not be the case, but
Well, the rules have somewhat changed, and it's somewhat payer dependent. So that I'd say historically, most surgeries, if we were looking at, we're kind of focusing on the surgery, not just all the medical aspects, but I think that's appropriate for this kind of presentation. But from a surgical point of view, from a practical point of view, we'd have people that had more than 15 events per hour on a sleep study would be generally eligible for surgery. So surgery would be covered for more moderate and severe sleep apnea. And after the last American Academy of Sleep Medicine's position paper, where they actually advocated for palatal surgery anyway, for more mild or moderate disease, a few of the major carriers actually changed the policies where they'd actually not cover for palatal surgeries in more severe apnea, and they would actually cover it for more mild apnea. Usually they had the caveats, though, of having not only failed CPAP, but also failing sometimes oral devices.
Right.
But
for snoring, have you ever?
Well, in a sense, I would say that the vast majority of patients, if I have a middle-aged male who comes in and is snoring and is in my office, the likelihood that they have an apnea-hypopnea index of less than 5 events per hour is small. Almost all these patients will have more than 5 per hour. In fact, I tell patients as an outset, I mean, to me, the definition of snoring is, mild apnea and snoring are medically and clinically equivalent. So if someone comes in with snoring, assuming that they actually really do snore, that it's not like you said, just the loud breathing. If they snore, they've got mild apnea. Snoring is not normal. And maybe on any given night, you may get a sleep study with some number, either, maybe in some cases less than 5 events per hour, in some cases more than 5 per hour. But if somebody comes in with, they have no associated comorbidities, they're not particularly sleepy, and the main concern is the nocturnal noise of snoring, that's mild sleep apnea. Yeah. And I would treat it as such. And it's important, I think, actually also to note that for the younger patient that comes in with mild sleep apnea, is that with aging and weight gain, that's going to become more moderate and severe. So that's certainly, we're treating this as a chronic disease. As you mentioned, not only is there a relapse, but also there's some chronicity to it. And so you want to be sure and treat patients in that way, so you can follow them up long term.
Yeah, for sure. I that's another part of for me anyway, the management and discussion is that trying to get them to understand the chronicity of it. Just to touch again here on the implants, somebody had a question in regards to reaction. Paul, I think you've done this more than maybe exclusively you at this point, because not a lot of people have experience with the alevoplasty, but do you have kind of a implant reaction, or is there much of that strange kind of foreign body sensation with the alevoplasty versus the pillar? I know my experience with the pillar implants certainly is that everybody knows a little bit about extrusion and stuff like that, and they can migrate over time. Have you seen anything, or how does that compare between those two types of implants?
I haven't seen it yet. I have seen some discomfort kind of in the short term, perhaps a little bit more than what I would have seen with pillar, particularly with the 2 lateral ones. And that was my first couple of cases. It was transient. I haven't followed these patients long enough to know if there's going to be any sort of migration or delayed exclusion. With pillars, I remember seeing a patient that had pillars years before, and the implant migrated all the way to the anterior tonsillar pillar. Very strange. But of course, we haven't been long enough to know.
Yeah, so I think that one of the worst procedures I've ever done on somebody was a capso. That certainly is going to generate a lot of calls back to the office. Some of these other, less or minimally invasive techniques are less so, but easily manageable, I would imagine, in terms of the discomfort that you saw with those alevoplasty or pillar patients. But, it's just something to consider in terms of, how it goes. I think the alevoplasty, though, as the way I understand it, it's easily trimmable if something extrudes, versus the pillar. You almost have to put your foot on their chest to pull that thing out of the palate if you're doing it in the office. It's tough. It's tough. The scar that generates around those, I think, is pretty substantial, and yet they still can migrate. I'll touch on another topic here. Let's get the input from you guys. I'm in a situation where I just changed practices. I moved entirely from one continent to the other, so I haven't quite figured this out. But there's a question here from one of the attendees saying, "How has COVID impacted your office snoring and sleep practice? Besides patients not being able to come to the office, have you had to manage things differently in terms of PPE and how you do some of these procedures? Or are you avoiding to do them altogether, or something like anterior palatoplasty, which can generate some aerosolization, perhaps less ideal in this setting versus putting a quick implant in? What do you guys think?
So in our practice, and actually it's mainly with the nasal procedures, and actually I know there's a question on the list also about combining nasal procedures with palate procedures, and that's very commonly done. So I'll do a turbinate reduction, radio frequency reduction of the turbinates commonly with some of the palatal procedures for snoring. But all those patients get COVID screened. In any sort of more invasive procedure, when there's going to be any incisions and possible coughing and aerosolization, we're doing that in the surgery center now. I mean, you have really good PPE and you have the appropriate materials. They can do the turnover for the rooms. And my clinical offices just aren't prepared for that. So I do any sort of invasive procedure then in the surgery center, aside from just like nasal turbinate reductions, which we still do in the office, but they come in 3 days ahead of time and get their COVID swabs and are screened. I do also tell people I really want them, especially as we're having an outbreak here in Wisconsin, I really tell them I want them to semi-quarantine for a week ahead of time. And I tell that even to all my other surgical patients that, yeah, they're going to get screened 3 days before, but I really want them to avoid getting sick around the time of any sort of intervention.
Okay. Paul, are you doing anything different, or would you change one technique versus, go gravitate towards something to minimize the contact exposure risk?
I think that's reasonable. Anything, of course, as the more you can avoid any aerosolization, I think that's always a good idea. And certainly some of the implants, the implant techniques, do that. We like Tucker says. I mean, we also test our patients. We actually do a double test. We test them a few days ahead of time because that's the turnover for the hospital lab. But then we have a rapid test in the office as well. So we test them on the actual day of the procedure once more. And then we have them do an oral rinse in the early stages of the pandemic. If you ever get into the ENT forum, there was people advocating for some of these iodine-based oral rinses, which apparently there is some evidence, that they can be effective, in clearing some of the virus or, if there was any there. So we have them also do some of these molecular iodine oral rinses prior to the procedure. And then, of course, we are in full PPE. I try to avoid microdebrider-based techniques because that can, again, lead to a lot of aerosolization, plus, of course, what's being suctioned into the canister and whatnot. So we try to do, gravitate a little bit more towards radio frequency, or even something called a tissue welding technique. I'm talking about for uvulectomy, for example, or a uvopalatal flap. There's a technique called NSEPs or ENT SEPs, which is analogous to a harmonic scalpel that you can have in the office. And that's proven to be quite effective. And it seems like, it doesn't really aerosolize much because it's more about welding the tissues together. So those are some of the adjustments we've made, and, of course, in the hopes to avoid any exposure.
You kind of, both alluded to a couple of the techniques there you'll use for the nose, but prior to actually doing a procedure specifically on the nose, is there something like a nasal test you have them do? I know, Tucker, when I was with you, and I do this to some degree as well, I'll have patients do kind of maximum decongestion for a few nights. Mm-hmm. Have them on a steroid, try some breathe right strips, and then kind of report back to me after doing that for a few nights in the right sequence, as kind of a maximum nasal test to see how they responded to that. Do you guys have a technique or approach to addressing, trying to figure this out?
I still do what I call the maximum nasal test, where I have them use usually some sort of nasal dilator, There are also some internal splints. One of them that's commonly used is called Mute, M-U-T-E. It's an internal diesel. It's made in Australia, actually made for athletes, as well as just topical Afrin or some other oxymetazoline type of medicine. And we have them try it. I don't think the sensitivity is all that high for picking up people, but it's probably fairly specific. So if people respond to that, it's probably pretty favorable for snoring. I see it more for issues of actually other sleep issues, for example, like using the ability to use and tolerate CPAP, or for some of my insomnia sort of patients, that it's probably more useful than just strictly for snoring, but it gives you some idea. And I find that probably one in 15 or 20 patients will notice a significant improvement just with the decongesting. I know from a nose point of view, within our region, there are a couple groups that are very aggressive on the balloon sinuplasty for snoring, and that's, I think, quite controversial, and is a topic I'd rather just avoid at this moment. But
yeah, I'm not aware of any literature which supports doing that.
But
sure.
one of the things that actually is interesting, in all this, I kind of look at it as for me, I'll call it the 3 Ps of snoring. Is that you kind of look at the characteristics, like is it positional or non-positional, so you can actually throw in things like just simple elevation ahead of bed. I call it the sleep number adjustable bed sort of treatment, or sleeping more on their side versus the back. There are some positional devices you can purchase them if you want, that actually they're wearables that can go with smartphone apps, or they're just wearables you can get. I think, as you said, the partner effects, really assessing, what's the issue with the partner making, and that's where things like this, using the Snore Lab or some of these apps can really be helpful, because sometimes when you look at it, people only snore for very brief periods of time during the night, but the most common times people snore is right at sleep onset and at the end of sleep when they go into REM sleep. And some of those people, I think, are a little bit easier to treat. So if somebody has positional snoring, or really, very limited times of snoring, I think that's probably an easier patient group to treat, especially if they have more favorable anatomy, like, the Mallampati 2 versus Mallampati 4. I think those are factors we've never been able to measure before. We just, people would come in and complain of snoring, and we treated them all the same, and they're really not the same. And so I think you can actually maybe stratify people into more favorable groups as we go forward. And then last, as you mentioned on the things, is then the kind of the pattern of snoring. And I think we don't really have currently good acoustic ways to look at it. I think that will probably change with some of these apps will probably give us more information. But I listen to the type of snoring. Is it a low pitched, kind of what I'd call low pressure snoring, kind of this, it's low frequency, not a lot of energy, versus a high frequency, high energy, kind of that fricative snoring, which is that's again more associated with apnea. And even also when it starts on the breathing cycle, if it's more on the early onset of breathing, kind of that, so at the beginning of inspiration, the snoring, that tends to actually physiologically be less obstructed than the person where it's later in the breath, where they're breathing in, they go, where it's that kind of escape at the end of that. And actually interesting, as you mentioned, not only frequency pattern, we're seeing now there's some literature out there on the sleep apnea group, that when you look at the airflow pattern on a sleep study, there's certain anatomy types you will be able to pick out based on an airflow pattern. So I think there's a lot of interesting stuff that's coming down the pipe, actually, and it's going to help us change how we treat snoring.
Yeah, and that, just to highlight that, if people are interested, I think it's Danny Eckert down in Australia, and White in that group, and then Alan Package. He just did a talk for the ASM, and it looked at AI and how they're looking at some of those things and picking up on things in sleep studies for sure. So the flow is important. So yeah, that's a good one. There's another kind of question I had here. Let's see. How do you kind of choose what snoring procedure? What do you think? Is it kind of patient comes in and they've already researched it, and then they're going to say, this is what I want, or this is what I'm interested in? Cost reimbursement, you mentioned a little bit earlier. How about pain level? Like I said, the capso was something we would go to when I was a resident, but that generated a ton of calls, and and we tried to get away from that as much as we could, just because with anything, you try and reduce morbidity for the patients. So something that's more tolerable gets them back to work quicker. But are some of those things, are you trading off effectiveness? And what are your thoughts on that?
So what I've seen, not just with capsule, I don't think I did it maybe in training, but I've never done one afterwards. Some of the radio frequency based techniques are also very painful to recover from, then you find yourself, like you mentioned, getting all the phone calls, and then you feel tempted to perhaps prescribe some steroids to try to help the patient kind of navigate through that pain, but then you're potentially compromising, the development of scar tissue, which is ultimately what you want to achieve to have a better outcome. So it can be quite challenging. You also don't want to be overprescribing narcotics, and getting into that sort of problem as well. So certainly it's a balance, what the patient is a good candidate for, what they're seeking to accomplish, and then what they're going to be able to tolerate or go through, not just in the recovery period, but actually going through the procedure itself. You're talking about doing it in the office, you have to look at the gag reflex, you have to look at the levels of anxiety that patient's going to have going through the procedure, because of course you don't want to compromise or shortchange, your procedure just because the patient's just not tolerating it very well. So I think those are all the elements that you have to present to the patient, before committing to one specific technique and going forward with it.
Yeah, I think a balance of, understanding, having that conversation with the patient for me is important. Understanding kind of what their expectations are. And then another couple things that are, I always try and remember to touch on with the patients are asking them kind of socially, what their job is, what they do, and then what their hobbies are, because I have a sister-in-law who's a vocalist, an opera singer, and she snores, from what I understand. And she doesn't want anything done to her palate because she's afraid it'll change her voice, right? So you look at some of these other non-invasive things, perhaps oral appliance, stuff like that. And then people who are, wine connoisseurs or sommeliers or foodies, which is, more common that we come across, perhaps. If you're doing some resection of the palate, maybe that's going to disturb or change their voice, change their ability to taste and stuff like that. So that balance, and then if they have a gag, all those considerations, I think what served me best is to have not just one tool I always go to and gravitate to, but look at kind of the options and have that discussion with the patient. It can be a long discussion sometimes, but it's helpful because 2 years down the road, when it's relapsed or it's kind of coming back to a degree, kind of where do you go from there? So for me, it's a balance of a lot of those different characteristics. And I don't know if you guys feel the same or what's worked for you or been problematic in the past. And so what are your thoughts?
I think it's like you say, you have to kind of go through a stepwise procedure. And since the following session I know after this is dealing with oral appliances, I'll really skip over it, other than to say my ladder approach. So my first, obviously, step in the ladder is just conservative therapies. We talk about positional therapy, weight loss, really maximally treating the nose on the medical basis. And then if that's, persisting, one other thing we'll use is there's a device called Theravents. It's a little nasal tape. I don't really have patients that use it generally long-term, but especially short-term, it's actually pretty effective, and 30 to 50% of patients can actually even use it long-term. But that's kind of the person that comes in, in the day and age when somebody would come in, obviously not an issue right now with COVID, but they'd come in and say, "Doc, I'm going on a cruise next week. I need something."
Yeah.
And so something is called Theravent. They can get it on the internet, and it's actually pretty effective, actually.
Yeah, the data, I mentioned that in the other talk, was more the data that came from Provent, where that originated from, but then the single strip Theravent, yeah, I've had exactly that scenario where patients said, I'm coming in, I'm going to travel. And then they came back and they did have, it was effective for them, and then they stayed with it. So, yeah. But it's not always a tolerable thing for some of my patients, but I haven't used it recently. But yeah, I found
so it's available. So then the next step for me is to go to oral appliances. And I actually have two strategies there. If somebody has sleep apnea and they've gone through CPAP, they can get it covered by insurance, and we go with the more high-end kind of custom devices. We also have some non-custom devices that we use, and we've actually worked out a strategy. Some of these devices are actually prescription-only devices, and so I have to write a prescription, the patient gets the device, and then we assist them with the fitting. So usually they have, 2 or 3 visits with us to work on the fitting and getting the devices there, possibly even getting some sleep studies involved in that. And then the next level then is what we're talking about for these talks, which is the surgical interventions. So if somebody's coming in to see me and they're doing, let's say I'm doing a radio frequency procedure on their turbinates, I can use the same wand actually with a little manipulation usually on their palate. So I don't usually use a separate one. I'll just do it at the same time.
Right.
And I actually wrote about it a few years ago where we do some radio frequency, the lateral palatal fat pads in the uvula. And we actually had short-term at a year, at a year's period of time, we had almost 100% success rate. So it was really quite successful. But as I looked at those people out, like I say, 2 years out, there was a really high relapse. So people would eventually bounce back, but, it provided them with a benefit for a period of time. So if I've got the radio frequency tool in my hand, well, I'll use it as an additional one. I did do, prior to the discontinuing of pillar implants, I would do those. But as Paul said, I'd almost always do the pillar implants with some other combined procedure. I found that the pillars by themselves were just not very effective, but they really probably significantly increased, I thought, at least in my hands, the effectiveness of some of these other procedures. So I could do like a uvulectomy or a conservative anterior palatoplasty in the office and combine it with the pillar implants, and I really felt like I got a significantly better success rate. And actually, there's even some data to support that based out of Korea. So that was kind of my stepwise approach as I would go through that combined implant palatal anterior palatoplasty is my final step in my ladder.
Okay. Yeah. Yeah. Thanks. The oral appliances is something that I haven't tended to do as much in the office directly myself because I have close dental colleagues and stuff. When I was in the military, I could, we utilized it. We did a lot of that certainly in our sleep areas with the dental colleagues, but that can be very effective in that regard. Ofer Jacobowitz, he just did a session the other night on oral appliances, which if you're interested in that, that's a good one to look at. And then I think there's one to follow this. So do either of you feel that you've had an uptick in patients during this kind of COVID time period that are coming in wanting kind of stuff done in the office, or because of unavailability of getting into the operating rooms early on, and now is it more something that you found change over time where people gravitate towards wanting to do just stuff in the office, either during COVID or in general?
Definitely with COVID. I mean, the people seem to feel very comfortable coming to the office and, going through with procedures of all kinds. When you bring up, the potential for operating room or hospital-based care, then yeah, there's definitely reluctance there for anything that's not, of course, dangerous or life-threatening. So I think that in the one sense, people, of course, are more at home, nowadays. And I think a lot of people are weight too because of the pandemic, people are just working from home, just thinking about eating constantly. So I think a little bit of a topic there as well. And then, there's been just in general increased awareness, not just of snoring, but sleep apnea in general. It's on the media, it's everywhere, people are talking about it. So with that increased, I think, focus and attention, in the patient population, I think at least where I'm at, I've seen an increase there, for an interest for these types of procedures as well.
Yeah.
Have you found that like wearable technologies and stuff like that are really kind of cluing people in?
Yes, I think that's a very, very excellent point and very important factor. People are tracking their sleep using all sorts of apps and their, wearable devices, and, getting all kinds of numbers and indices on sleep quality, and who even knows what those numbers mean, but people are definitely paying attention to it. So
yeah, we're seeing a big uptick. And in fact, even this week, the new Apple Watch has some more sleep wearable, but it's not really so much right now linked to breathing, but I really think that's going to change. I think people will begin to understand how some of this wearable information is really linked to some of the breathing issues during sleep. and
Yeah.
we're going to see a big. I think it's going to be I think it's going to be transformative for sleep. Quite honestly, I think it's. I mean, honestly, for the whole field of sleep medicine, not just oto sleep, but it's going to be transformative. And I think us as airway doctors, as kind of the premier airway doctors, hopefully we'll be on the cusp of this to really help change and modify how it's going. Because I don't think the answer is to take all these people and run them to the sleep lab.
No.
I think we have to have a better way of treating these people. And
Yeah.
and snoring is kind of the cusp. Like I say, snoring is mild sleep apnea, and that's the majority of people that have sleep apnea are people that have mild apnea. And we need better ways to treat it. And it's exciting. We do have some new and better ways to treat it. I think they're going to continue to evolve and get better.
Yeah, the ASM's sleep meeting session, they had a session 3 or 4 weeks ago on specifically dedicated towards wearable technologies, and it's really across the breadth of sleep medicine that the wearable technologies. Now, a lot of them are not validated, and they're not giving, consistent data. So it's not every piece of wearable technology is giving you the information you need, but it's a jumping off point for at least the discussion in the office. And then some of them give you very good data, which, like you said, I think we'll be able to analyze and get a better idea. And in the case of office management of snoring, there might be characteristics of either that sound frequency, the character of it, when it happens during the night, that clues you in perhaps even to where, one procedure or one targeted therapy might be better than the other, whether it be positional or a type procedure. And the one study, I commented on that Scott Britsky did with Eric Mayer. I mean, they showed that if a person doesn't have palatal snoring, any palatal procedure they did was going to be less effective. I mean, it's kind of intuitive. But then for the alevoplasty, they did a little bit of that as well. But the authors didn't then stratify and select out those patients. So in that article, I found it interesting that even though they used the SNAP study, they didn't select, from what I understand, patients that had that specific palatal snoring, so that the procedure outcomes might have even been better if you can select some of those patients. So that data, as that data package expands, it becomes better for us to analyze and understand it more. Certainly will help with our understanding and our management, I think, of the sleep patients, but then also for things like this, what technique might be most beneficial for the patients, and something to kind of think about. So yeah, those are good comments. And then I wanted to bring up this other question, and I'll look through the chat rooms and stuff here again, but what are some key side effects or complications, and when do you guys tend to see your patients back after doing some of these snoring procedures? What's your kind of follow-up for these patients? What do you tell them?
I will oftentimes bring them back about 3 weeks after, considering, of course, I'm doing a combined nasal procedure very often on these patients as well. So I like to see them about 2 or 3 weeks out, typically 3 weeks. That's a point where, of course, the pain, the initial acute pain has subsided, and they've been, perhaps using a saline spray, to kind of heal from their nasal procedure, so you can bring them back and do a little bit of debridement if needed, and check and see how everything is healing. And then, of course, at that time point, they're starting to see, of course, the effect of the combined procedure, or maybe just the pure procedure in the palate as well. And then you can start really asking them about how, how's it going? How is your snoring starting to sound to you, to your bed partner? So that seems to me like an initial, good first visit. And then after that, of course, it sort of depends. But I do have my patients coming back on a periodic time point to kind of check on them.
Yeah, so for me, it's if I do an anterior palatoplasty, I see them at 1 week, because I want to, with the narcotic restrictions, if they need a refill in narcotics, I can refill that at a 1 week if they should need it, and occasionally they do. And for the nasal procedures, I'll see them at 1 to 2 months. Obviously, they come in sooner if they're coming in. I say if you're really noticing a lot of crusting and congestion, because when I do the radio frequency reduction in the nose, especially, depending on the patient, I may be more or less aggressive. And if I'm more aggressive and we're getting more mucosal damage, then they're going to have more crusting and healing. And so then I may have to, gently debride them a couple times.
Yeah, those are good comments. For me, I typically, depends on the procedure, of course, but I always try and let them know up front that their snoring may actually get a little bit worse, especially when I'm doing some of the resection techniques because of just some swelling in the palate. But really that scar that's generated, that some of the initial data and stuff I think they looked at for scleroplasty was, you're not going to see really the effect for 6 weeks out. I tell patients probably even a little bit more than that. So you're not going to see a reduction. So it's in that month time frame if I'm doing a palatoplasty, and then we're doing phone calls if they need management with refill and medications. And I've been very surprised with the anterior palatoplasty. I've had and I tell patients this. They say, what should I experience as far as pain? And it's, I tell them it could be a spectrum. I've had patients I've done the palatoplasty on in the clinic and they go back to work, or they felt they could have gone back to work a couple days later, which really surprised me. And then other ones at a week or 10 days that are looking for kind of answers in terms of how they get through the next couple of weeks. And it's it's a big spectrum, and it's hard for me to predict. And I don't know if it's because of a variance in technique that I'm doing. I think I do pretty consistently the same thing, or if it's just different innervation of their palate or their sensitivities in general. But, I counsel them based on kind of when I think the snoring is going to modify from baseline, and then kind of, the pain expectations and stuff like that. So it'll depend on kind of what feeling I get for the patients and stuff. So
one of the things I noticed on complications, if you were in the anterior palatoplasty, is, and I think it's important to note, is that when and I don't know if you see it with the alevoplasty as well, maybe to a lesser degree, but you really will see some VPI. When you actually shorten and pull the palate up, those people will actually have kind of a hypernasal voice for a few days, because you're really not fundamentally affecting the muscles or other functions of the palate. That's going to get better, but it's not at all unusual that, even in the immediate post-operative period when you're, finished putting in your final stitches, that the patient really is, changes their voice. They'll have a more nasal voice, and maybe have a little nasopharyngeal regurgitation with swallowing of liquids. That's very, very common in my experience with anterior palatoplasty.
Yeah, no, I concur. I talk to patients about that as well, and that's, at first, for people who may be listening and they haven't done it in the office, or they do it in the operating room, depending on their technique, that's a little unnerving at first. But yeah, I found that to be the same thing, for a few days, even up to a week. Sometimes I'll have that little bit of nasal regurgitation or change, but it tends to fade. And like you said,
I've never had one that persisted. It's
right.
Because you're just tightening the mucosa, and that stretches back out. In fact, you'll see the incision line. It's interesting, the incision line in the anterior palatoplasty that starts kind of in that middle lower third of the palate. When you see them back a year later, that'll actually be kind of more inferiorly placed. And I think that's just the stretching of the tissues again over time.
Yeah, and yeah, I agree. Now, the other thing to mention quickly is that, Paul, you had talked about it, and Tucker as well, that you address the uvula. And I think the literature is pretty consistent that if you have a longer uvula and you don't address it, you're not going to have as good of an outcome. For me, I tend not to cut the entire uvula off, but I will trim it, certainly at least the redundant mucosa. I think preserving it decreases that little bit of kind of foreign body sensation they may have. That's more traditional with the UTTT, but I do trim the uvula quite a bit. And Paul, you said that that can be a source of the discomfort for patients, and I've found that to be the case as well. I tend to put chromics in at the base of the uvula, and those may not last as long. So if it dehisces a little bit, that's when the pain, I think, rises a little bit. But overall, yeah, those are some good general things for us to think about. So I know we're getting to the end of the session here, but I want to just take one last look and make sure that we've addressed as much as we can the chat and questions. Let's see if anybody else had anything. I know at the end here on the next slide, there's the emails for the three of us. And if people, have questions and stuff, they can contact us and let us know, what those questions might be. But I think overall, hopefully those were some good things. And I'll reference again, I think right following this in another virtual room, there's a oral appliance discussion, and there's some other on-demand ones, including one where I tried to go into a little bit more depth on snoring. And then Ofer and Robeson and Boyd Gillespie that had some other talks on snoring as well. I think Mike Freakman was in there. So a lot of good discussion out there about snoring and different techniques. And, you know, I'd like to thank everybody as we wrap up here for participating in the support from the AAO of doing this virtual meeting. I'm not sure where the meeting's taking place next year, if we can do it. Does anybody know? Is it out in San Diego with you, Paul, or where is it?
Hopefully, but I really don't know. We'd love to host you all over here. That would be great.
Usually I find out that next year's meeting I find out when I go to the meeting. I should know. They publish it ahead of time, but yeah, I think we'll actually be meeting. I think next year will be face to face.
Yeah, I'm hoping so. But yeah.
The conference is in Los Angeles, October 3 through 6, 2021.
There you go. So. All right. Well, right now, I think at least Tucker and I, maybe Paul, we were expecting to be down in Australia for the surgery sleep meeting, but that's not happening. So
no,
here we are, and this worked hopefully from all corners of the U.S. and central U.S. So I think that's it. You guys have any other comments before we let everybody head to their next room?
We're good. Thank you very much. Thanks, everybody.
Thank you, everybody.
Thanks again to the AAO and Cook. Appreciate it very much. All right, Paul.
This concludes our session. Thank you so much for joining us today and enjoy the rest of your AAO virtual event. Thank you and have a fantastic rest of your Saturday.